Good evening, everyone, and welcome to tonight's HRI Talk. My name is Hillary Dort, and I'm the Manager of Communications at HRI. Thank you for joining us tonight for our discussion, Untold Stories, Shaping Research for Women's Mental Health. For those of you joining us for the first time, HRI Talks present new ideas, discoveries, and studies that are helping to transform the mental health and substance use health landscape in Canada and beyond. Tonight, we'll explore the knowledge gaps and the latest research in women's mental health and discover how people with lived and living experience are contributing to the rapidly evolving field of women's mental health research. Please note that closed captioning and live transcription are enabled for this event. If you'd like to use these features, you can click on the closed caption or CC button on your Zoom display. You can also toggle on live translation in the same place. I'd like to begin this evening by sharing that the offices of HRI are located on the traditional lands of the Anishinaabe, Attawandaron, Haudenosaunee, and Métis peoples, and the treaty lands of the Mississaugas of the Credit. We support the Truth and Reconciliation Commission of Canada's calls to action, and we are continually working to be more inclusive in our research and in our everyday practices. We want to do our part to promote reconciliation and healing, and we invite any input you might have on how we can do better going forward. So for those of you who are not familiar with HRI, we conduct applied research with a goal to improve mental health and substance use health services in ways that can benefit more people sooner. We work with leading clinicians, people with lived and living experience, and researchers from across Canada and beyond. Finally, before we begin, I'd like to extend our deepest gratitude to our corporate sponsor, CIBC, and our supporting sponsors, KPMG and the Otsuka-Lundbeck Alliance. HRI Talks would not be possible without the generous support of our sponsors. Thank you. Our moderator this evening is Hannah Sung, journalist and co-founder of Media Girlfriends, an award-winning podcast and video production company in Toronto, Canada. Welcome, Hannah.
Hi, everyone, and thank you so much, Hillary. Nice to be here tonight, and we are so pleased to have over 270 registrants from 8 countries for this HRI Talk tonight. Thank you so much for joining us. I'll also have to just apologize a little bit for my voice. I'm a little bit under the weather, but we're going to do our best. Now, tonight we have a really fabulous moderated conversation on deck for you with some expert panelists. This will take approximately 20 minutes, and then after that we will shift to answering questions from you, the audience, for another 20 minutes. And we would love to hear from you, so if you have questions, please use the Q&A button at the bottom of your screen at any time during the presentation. The questions will collect there, and we'll get to as many of them as possible before we wrap up at the top of the hour. So now I'd like to introduce our panelists who are here to share insights from their research, clinical practice, on the job as doctors, and from their personal lived experience as well. So joining us this evening are Brydie Huffman. She is a member of the Community Advisory Committee at the Women's Health Concerns Clinic at St. Joe's Healthcare Hamilton, and a person with lived experience. Welcome, Brydie. Also, Christine Vanderveen. Christine is also a member of the Community Advisory Committee at the Women's Health Concerns Clinic and is also a person with lived experience. Hello, Christine. We're also welcoming Dr. Melissa Perreault, Associate Professor at the Department of Biomedical Sciences and the Research Leadership Chair at the University of Guelph. Welcome to Melissa. And to Dr. Benicio Frey, the newly appointed Homewood Research Chair in Women's Mental Health and Depression, also a professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University, and the medical director at the Women's Health Concerns Clinic at St. Joseph's Healthcare Hamilton. Hello, Benicio. Well, we've invited all of our panelists here today with 3 goals in mind. We want to gain insight into the unique factors influencing women's mental health and to understand the knowledge gaps in this field. We want to examine the importance of training and education in mitigating the impact of stigma and societal misconceptions on women's mental health. And finally, we want to explore emerging research and understand how individuals with lived experience contribute to shaping this research. So I'm very excited to dig in. Everybody can start to turn on their mics. But first, I just want to say a note on language. Our discussion this evening will refer to women and female reproductive life phases. And I want to acknowledge that not every female identifies as a woman and not every woman was assigned female at birth. Also, in case you didn't know, today is World Maternal Mental Health Day, which aims to increase awareness of mental health issues before, during, and after pregnancy. It's a very important topic, which some of our panelists will speak to. And we also want to bring awareness in general to women's mental health during all life phases. So I'm going to start with you, Benicio, if I can, with our first question. There seems to be a lot more conversation on mental health in general in recent years, but I'd like to start by asking you specifically when it comes to women's mental health. How is women's mental health unique?
Thank you, Hannah. I just want to quickly thank HRI for this kind invitation, and I'm thrilled that there's a forum like this open for us to discuss women's mental health issues, and I'm thrilled to share this experience with you, Hannah, Christine, Brydie, and Dr. Perreault. Thanks for having me here today. So yeah, there are several things that we can say are unique in women, and several other things that are equally important that are more prevalent in women. So if we want to do the right job of really trying to accurately understand women's mental health issues, and most importantly, how we can best help them, we need to understand those circumstances. So I'll give you some examples what I'm talking about. One is how the brain develops, right? If we compare those assigned males or females at birth, the brain develops differently. Then in puberty, there's the hormone that hits all the body and hits the brain as well. So there's further changes in the brain development that are associated with hormonal changes. Then there's a significant proportion of those who are assigned women at birth that have face mental health challenges related to their, for instance, menstrual cycle, particularly the premenstrual phase, pregnancy. We all hear about postpartum all the time. Nowadays, more and more, we talk about the challenge in the perimenopause, which is not like a single event. It's a series of events that happen, events that happen across 3 to 5 years, maybe for some people even longer. So there are many unique aspects of women's mental health that are really important for us to understand. And then there are other factors that when we talk about mental health, it's 99.9% of the time not a single cause. The causes of mental health conditions are, we call, multifactorial, or many causes, not just the biology. There are other psychological and social aspects of mental health that are equally important. And when it comes to the social aspects of mental health in general, we know that unfortunately women are more exposed to traumatic events, are more exposed to interpersonal violence, more exposed to harassment, even at work. So there are many things that are, perhaps not unique to women, but more prevalent in women that we need to also understand, and account for when we talk about women's health issues. So I'll stop here, and I'll be happy to answer more questions later on.
No, it's a very good primer and overview on what makes women's experience of mental health unique. And I think even for the layperson such as myself, we have all heard about a research gap when it comes to women and mental health. It's very persistent. Melissa, I'd love to bring you in here and ask you about that persistent research gap. As a researcher yourself, can you help us understand how this happened?
Sure, thanks, Hannah. I guess the first thing I'd like the participants, the audience, to understand is that to learn about mental health, there's two areas of research that we focus on. So we have our clinical research, where we actually have patients and we look at women, and then we have our preclinical or translational research, where we use cell models, animal models, and these are very mechanistic in nature, new target identification, new biomarker identification. So very mechanistic. Historically, for decades, we have focused more on male subjects than we have female subjects. Now, when it comes to translational research, we have used predominantly male animals or male-based models. There have been several reasons for this, not necessarily the best reasons. For example, researchers were trained in such a way where we were told that, females were more variable, their cycling caused variability to the data. So it's just easier to leave them out of the studies. Another reason was money. So if we're going to look at the males and the females, then it's going to cost twice as much to do the research. Timing, if we're doubling our studies and doubling our animal use, it's going to take twice as long. So I would argue that if it needs to take twice as long, then it needs to take twice as long. And if it costs twice as much, then it does. Because this is information that we need to know, because we're really discovering that males and females at a very cellular level are fundamentally different. When we move to the clinical research, men and women were generally used in the studies overall, except sex and gender wasn't really taken into account as much as it should have been. So what happened over the years is we put ourselves in a situation where most of what we know about these disorders is what we know about men or male subjects, and our treatments are based on what we know about men. So I'm sorry to all the women in the audience, but we really have, I think, gotten the shaft when it comes to knowledge regarding mental health and other disorders and diseases in general. But hopefully things are turning around and we're moving in a better direction.
Yeah, I find what you're explaining, Melissa, to be so fascinating from the research level in the lab, but then clinically as well. Historical biases, none of which are fair. Thank you for that. I would like to launch our first poll now, just to read the room and to understand who is here with us and how you're thinking and feeling. This is our first poll question. How informed do you feel about mental health risks that are specific to or more prevalent among women? Somewhat informed, not very informed, not informed at all. So no pressure. This is not an exam or anything like that. It's just to get a sense of how you feel coming into the room tonight. Go ahead and click on one of the options, and it should tabulate for us as we watch. And it's a good opportunity to self-reflect as well, to really put that question to yourself. How informed do you feel about mental health risks that are specific to or more prevalent among women? And apparently the panelists cannot vote, but everybody else here in the room can. Now I wonder if I'm going to be able to see the results, because I know in the past I've been able to see them right away. Does anybody else see the results? No, I don't see the results either. Oh, here they are. They just flashed on the screen, but then I lost them. Okay, so the top answer is somewhat informed, 57% of you. And then next is not very informed. Not informed at all is only 4%. So it seems like most people in the room are here because you feel like you do know a few things about this topic. But clearly there's a hunger to learn more. So thank you for that. And Melissa and Benicio, I do want to come back to you in just a moment, but at this point, I do want to bring in Brydie and Christine to the conversation. Maybe I'll start with you, Brydie. I know that you're both members of the Community Advisory Council at the Women's Health Concerns Clinic. Can we start at the beginning with you, Brydie, and ask, how did you first get involved?
Great. Thank you so much for having me. So my work with the Community Health Advisory Committee began 5 years ago after I gave birth to my daughter, and I had never had experience in mental health barriers before giving birth. So I felt very lost in how to navigate the system and the paths to get me to where I needed to be. And at a time when all my other friends giving birth felt joy and abundance and wanted to be around people, I withdrew. I felt isolated. I felt ashamed. And I spoke to my family doctor and was told I was just tired and it would be fine. And a week later, I ended up in a psychiatric hold in the very hospital that I gave birth in. And I remember thinking at the time of having to pump breast milk in a psych ward that this is probably a good rock bottom to climb from here. And I ended up receiving cognitive behavioral therapy treatment from the Women's Health Concerns Clinic. And the impact that it made on my life was so dramatic that I wanted to be involved, and heard that they were starting a committee of past patients with lived experience. And I just found that there were ways I could involve myself, even though I wasn't from the medical field. So I could take my background in marketing and communications and use that to amplify our message. And I was able to do things like participate in brain mapping studies or research on the impacts of sleep on postpartum care. And most recently, we were able to produce a pamphlet that is now given to every mother that gives birth at St. Joe's Hospital, that gives them the tools to talk to their doctors when they've lost their voice, which happens a lot of times for patients who experience depression. So it's been an ongoing thing, and Dr. Frey has made sure to include people from all different aspects of women's mental health care, and we're just really proud of what we've been able to do.
Well, I want to just start by saying I'm so sorry that you had the postpartum experience that you had, and I'm so glad that you were able to get the help that you needed. And you've already kind of explained the broad strokes of what your involvement has been like, bringing your own professional experience to the committee. Can you tell us about any specific experiences that you're particularly proud of working with the committee?
I think one thing that oddly stands out to me is that we actually have a male pharmacist that joined our committee recently, which, although it's not my personal experience, it's so rewarding to see men participate in advocating for women's mental health. And that he is always talking about how we can bring in voices of those who are not middle-class, white-speaking English patients. And so to have other perspectives like that, especially men equally participating in the process, is something that is foreign to every other board or women's led committee that I've been asked to be a part of. And so I think that's something that is really different in this committee from other ones I sit on.
Yes, let's give it up for that male pharmacist, as it should be. Everybody needs to work together.
Yeah.
Christine, can I turn it to you for a moment, and can you tell us about how you first got involved?
Yeah, thanks for having me as well. I'm going to start back in 2014 when I actually was diagnosed with borderline personality disorder. And that was kind of an experience where I was just told I had anxiety. It wasn't a big deal. I really did have to fight for my care. And because I was very sick, the system was new to me. It took a long time. There was a year wait list. I finally did dialectical behavioral therapy, which was life-changing. And it worked. I worked really hard to get to where I am today. Then in 2018, I became a mom for the first time. And because of my history with mental illness, I was referred to the Women's Health Concern Clinic at St. Joe's, and things went relatively smoothly. I'm very thankful for that. But in 2022, I gave birth to twins, and the experience was totally different. At 2 months old, my twins, 2 months old, I was diagnosed with postpartum depression, and I don't even think I recognized it. It was something that my therapist and psychiatrist realized. I was still doing everything. I was going out, seeing people, taking care of the babies, but behind closed doors, I was full of rage. I was constantly questioning how I could do this. And I was kind of numb to my emotions as a mom. I was just going through the motions, and the joy was gone. And thankfully, I was being seen by Women's Health again, and with proper help with therapy and medication changes, I was able to come back around, and the fog has lifted. I joined the Community Advisory Committee after my firstborn, so I've been on it for four years now. And I knew that just after my own mental health struggles, I knew that I wanted to help the women that came after me. A lot of moms don't actually have the insight that I do about mental health and mental illness. So I kind of knew going into the postpartum period that I could struggle because I had a history. So I'm hoping that I can make the perinatal mood disorders something that parents and caregivers are aware of and know when to ask for help.
Thank you, Christine. And something that strikes me as you tell us your story is the similarity in not getting the help you needed right away at first, or not really having your own concerns validated in the beginning. And I'm so glad that you were with the clinic when you gave birth to your twins. I wonder, have you reflected on, how differently things might have gone in that moment in time had you not already been connected with the clinic?
Yeah, I mean, I don't know if I would be here. It was that dark. But I was, yeah, it's a struggle because I already had the insight that things could go wrong. So thankfully, with that insight, I was able to make the right decisions for myself before things kind of went wrong.
Thank you so much for sharing your story, Christine, and to Brydie too, because I know it isn't easy. And I wonder for Benicio and Melissa, as you hear their stories and if you think about the work that you're doing, can we talk a little bit about that with this research gap that we talked about earlier? I'm wondering if you see things changing. I know that the both of you work as educators with the next generation of experts, so to speak. Perhaps, Melissa, can I go to you first with any thoughts on whether you see the current research gap changing?
I do. And I think a big part of that is the funding agencies, whether it be through government agencies or charitable foundations, for example, they are making it mandatory to look at sex and gender when we do our research. So if we don't include male and female, men and women in the research that we do, it can actually cause us our research programs if we don't include them, because we go through review through our peers, and that's part of the adjudication process now. So, and it's not a matter of just including them, we have to compare them. So that is a big part of it. We can all say, oh yeah, we're going to include them, but that doesn't mean we're actually going to compare them and understand what the differences are. We do still have a little bit or a long way to go. For example, where we're getting better at including both sexes or various genders in our research. The problem is the pendulum's kind of swung the other way. So when it comes to researchers that want to look at women only or females only in a situation where it's not a woman or female specific health concern, those funding requests are getting denied. because people are coming back and saying, well, why are you not using males, or why are you not looking at men? You have to look at both. So it's good that we're including both men and women, or males and females, in our work at a translational and clinical level. Getting funding specifically for females or women in our research is still a problem when it's not a disorder or disease that's female specific. So we still have that hurdle that we need to get over.
Okay, so just to make sure I understand, if you're researching an issue that is sex specific to females, this type of research can be denied funding?
No, so let's say it's something to do with ovarian cancer or something that only women have, then yes, you can get funding for that. But let's say you wanted to look at depression, for example, that wasn't postpartum, but just regular depression that men and women both have, the reviewers would come back and say, well, why are you only looking at women or female subjects? Why are you not including the males? And that's where we're running into a little problem of, we're not catching up, I think, as quickly as we could when it comes to our knowledge surrounding women's health, because we are now in a position where researchers and funding agencies want it to be, I guess, equitable would be the word that they would use, to be inclusive of both sexes. So that gap is going to take a little bit longer to close, I think, not being able to focus on women, or those barriers are in place where we can't.
Right, thank you so much for clarifying. And because there is a gap, there needs to be some catch up.
Agreed.
Benicio, can you tell us also whether you see this gap changing based on what you see at work every day?
Yeah, thank you. I do. I honestly do. And I might be wrong, but I do believe from my clinical experience and being like a citizen of the world, that the pandemic has to do at least part of it, because COVID brought mental health issues as close to everybody as it could have done, right? So everybody was affected, either yourself or someone close, very close to you, including women's mental health issues. When I remember at some point in the pandemic that, for instance, mothers would go by themselves to give birth. They couldn't even bring their partner with them, totally vulnerable, with zero support from someone that they knew. Sometimes meeting medical staff that, of course, they are doing their best, but not always the person that is on call. So you're in a room with total strangers, everybody trying to help you, but nobody that is a familiar face next to you. So I think because I've been in this area for 16 years now, and I've seen a big shift after the pandemic, as far as, more awareness, more educational programs, funding agencies now taking, the sex and gender issues more seriously. So far as, there's a box that we all need to fill out, that how does your research address that, which is very good. So that's a shift. I think the younger generation also is more open to discussing mental health than the older generation. So there's about a generational shift as well. And then when it comes to women's mental health, we feel like it's a big yet small community, so it's so supportive. Like, we all support each other. Like, when you invite someone to do a program, you see that 99.9% of people you invite say yes. Like I said, everybody is behind the cause. And I think with this momentum that women's mental health is being more accepted as a big issue, a big gap, we need to do something about it. I've never seen so much support, both from foundations, institutions, public health, but also the funding agencies. They're so important to push the agenda forward and decrease the gap. So yeah, there's been an exciting shift towards better understanding of women's mental health issues.
I'm so glad to hear that. And maybe this is a good time for our next poll question for everybody who is here tonight. The question is, do you think stigma and negative stereotypes impact women's willingness to seek treatment for mental health issues? The options are absolutely, in some situations, no, and I'm not sure. There's no wrong answer. It's just a poll of what you think. You can go ahead and click your option. Do you think stigma and negative stereotypes impact women's willingness to seek treatment for mental health issues? We'll take a moment to see the results of that. Yeah, 70% of the people in this room believe that absolutely stigma and negative stereotypes impact women's willingness to seek treatment for mental health issues. I see Benicio nodding. I think we all probably agree this is a big reason or a big factor for why talks like this are even necessary for the public, for sure. Thank you for weighing in with your options there. I think it's a good time to turn now to the audience for questions. I know that questions have been coming through. Let's see. What we're going to do is we're going to ask Hillary to share questions that she'll be reading out loud off camera, questions that you have submitted through the Q&A button, which you can still continue to do. Go ahead, Hillary.
Thanks, Hannah. We've had a number of questions come in around risk factors for depression and age, specifically around menopause and postmenopausal women. Can anyone speak to research that's being done on depression in menopausal or postmenopausal women, and any treatments that have proven to be effective?
Who would like to take this one first, Melissa or Benicio?
I'm happy to take this one. Yeah, so this is a very important question. Thanks for the audience asking. Yeah, so we consider menopause like a transition. We call perimenopause or menopause transition, because there's a series of events that happen, both biologically and also, from a social perspective, in terms of, emptiness and, work life balance and so on. And then also the physical changes that happen with menopause that indirectly can also impact, mental health. But from a biological perspective, it's really important to understand that multiple studies have been done in multiple cultures, showing that the transition to menopause starts when the menstrual cycles start to become significantly irregular. And then some of the menopause symptoms can appear: vasomotor symptoms, hot flashes, night sweats, and so on. And that period of perimenopause and early postmenopause, early, I mean the first 3 to 5 years, many studies follow individuals when they were still menstruating regularly throughout the perimenopause until the late postmenopausal period, showing that clearly in that transitional period there's a peak, there's a higher risk of development of depression. And then there was a question: is this true only for people who had depression, that are going to have more depression in the perimenopause, or is this also true for people that never had depression before? And so there were studies done, like longitudinal studies, beautiful studies being done, and the answer is yes for both. So the perimenopause increased the risk for both people having more depression if they had depression before, or people having even their first onset depression. One of the question was age, right? Or there was someone alluded about age. So if you look at across all ages, okay, when depression starts the most, right? So depression typically starts late in adolescence, early in adulthood. So that's the peak when most of the first cases appear. But there's a second peak between 40 to 60 years old, right when at least half of the population would experience something called menopause transition. So we understand that that's probably true for at least half of the population. So people who have had oophorectomy, so if they had for any reasons medical conditions that they needed the ovaries to be taken out, they are also at increased risk of developing depression. So there's some medical conditions associated with gynecological concerns that can increase the risk as well. And then there are other risk factors like the sleep loss that can happen, in the perimenopause, something that we call cognitive struggles or cognitive decline. By cognitive, I mean how the brain functions. So menopause quite often causes people to, not be as sharp in their attention, not as sharp in their concentration, their ability to stay on task or task shift. That can have a significant impact at work, and that can, obviously directly or indirectly, cause anxiety or even depression issues in a lot of people. But last but not least, if you ask what's the number one mental health symptom in the perimenopause, it is irritability. So irritability is actually more common than even depression and anxiety. So what Christine was talking about, the anger, irritability, being short-tempered, this is actually one of the main, if not the most prevalent mental health symptom of those experience the perimenopause. So think about like a prolonged PMS. That's how, the most commonly the perimenopause occur.
That's so interesting. And, that's new information to me. And it really makes me think about how we were just talking about stigma and for being a reason why we don't necessarily talk about all the symptoms of perimenopause and women's mental health experiences during that age. I wonder, Melissa, if there's anything you'd like to add about your research on a cellular level when it comes to depression, specifically for this age group.
So I really don't have much to add. Generally, the work that I do for depression focuses on young adults. So my work doesn't really surround the contribution of hormones so much. Rather, I'm interested in elucidating non-hormonal targets for treatments. So I don't think I can really add much to answering that question.
Okay, and thank you. Let's go to the next question, Hillary.
Sure. So the next question is, how can we build trust with groups that have been underrepresented in research historically? And how can research be more inclusive?
Great question. Melissa.
So I can answer that. I'm from a minority group. I'm a citizen of the Métis Nation of Ontario. So I am very familiar with how minority groups can be treated differently when it comes to healthcare. And I think one of the things that we need to do is appreciate cultural differences and things that give us our resilience. So in Indigenous communities, for example, spirituality is a big component of that. Generally not considered when it comes to treatment and how that spirituality feeds into the resilience of Indigenous individuals. So I think that there needs to be, and maybe Benicio, you can speak to this, more training in cultural sensitivity during medical school. So those traditions or cultural approaches that build resilience in individuals can be combined with Western approaches to medicine to improve outcomes for patients instead of ignoring those other aspects that help patients cope. I don't know if Benicio, you want to add to that or where medical training is in that regard?
Yeah, absolutely, Melissa. Thanks for the opportunity. My former chair, put forward an opportunity for faculty to do the cultural safety training from Sandias community, and I did that and was incredibly helpful. And I'm so happy that we had the opportunity to do that. Research, we need, like I said in the beginning, we need to understand not just the biological components, but also the social components. To really make justice of any aspect of mental health that you want to do research on. I can give another example in terms of, we just spoke about menopause. If you go to the from Western world to the other side of the globe to Asia, you'll see much more rates of physical complaints versus emotional complaints in people that are suffering from mental health conditions like depression and anxiety. So if you don't understand the cultural differences, even how mental health is presented, you're going to miss a lot of the opportunity to help those people. So I'm with you, Melissa, that incorporating culture in the research is critically important for sure.
Thank you so much. Hillary.
Right. So the next question from our audience is, how do we know that women are twice as likely as men to experience depression or anxiety versus women being overdiagnosed or misdiagnosed?
This is an interesting question around diagnosis. I also just want to say that everybody on the panel is welcome to speak at any time. I just like to, try and help facilitate the conversation and guide the questions towards people who may want to answer, but anybody and everybody should jump in at any point. But specifically, when it comes to diagnosing, maybe Benicio, we'll start with you.
Can I add, Benicio, part to that question that I would love to know the answer to myself? And that is, I get some reviewer comments sometimes, and they suggest that depression isn't actually more prevalent in women, but rather men don't go to the doctor. And I would love to add that to that question as well, if you can address that.
Thank you. There are several answers, to these questions. These are really important. So I will start with the end then. So yes, so women have, in general, a tendency to come forward more, with more frequency than men. They tend to accept better diagnosis than men. They tend to have more insight about their diagnosis than men. They nowadays have a tendency to sign up for doing research more frequently than men. So we're actually having more trouble recruiting men to research these days, because women tend to be more giving, and they sign up, they collaborate, and participate, because doing research is not that simple, it's not that easy. It's a huge commitment on the research participants as well. So this is all true. Okay, now the research that has been done showing that women are twice more likely to develop depression, not just depression, but anxiety as well, during the reproductive years. Those studies were done in the community. So this is actually true. These are actually well conducted research that were community based. They use there are many ways you can do research in the community, like postal codes, or choose every other house and knock on their door. Like, there's several creative ways that you can do less biased research and get a true epidemiological survey of what's really happening in the community, in the world. And those types of research have been done in terms of depression. And yes, women are the depression is more prevalent in women than men. within the reproductive years. Before puberty, actually, depression has the same rate in boys and girls. Okay. And what happens late post-menopause, well after the ovaries have completely shut down, might suggest that the gap is not as wide, that is closer again. But certainly within the reproductive years, women are twice more, like 1.8, if you want the exact number, 1.8 times more likely to develop depression than men. Long answer because there are several elements here.
Thank you so much for that. Our next question, Hillary.
Great. So this is a bit of a double-barreled question. Someone has asked, how can you be a better support for a new mom who is navigating postpartum depression or postpartum anxiety, they specify? What can they do? And then we've had other folks ask about the return to work. So maybe if you could speak to how you can support people, but how you can also support a new mom who has experienced postpartum depression or anxiety when they return to work.
Okay, that sounds good. Let's start with the question about supporting a new mom. Brydie or Christine? Brydie, I see you have your mic off. Go for it.
I would say now, as someone who's experienced it, if I see signs of it in another mom, I don't make her do the heavy lifting of coming to me. I reach out to her first. I'm not putting that extra mental load on her to have to find the resources, to have to search it out. So I offer support in sending things, notice about the Women's Health Concerns Clinic. But other ways you can be supportive. Food is actually a very underrated, but like universally understood support system that just taking things off her list to do, send her the support links, drop food off once in a while. So being a part of her village. And I think that's one thing as becoming a parent, I didn't really understand how important that is to have. And your village might look different when you become a parent. Maybe it's the Uber Eats driver that's bringing things to your house, or maybe it's the nurse that saw you were struggling and advocated for you or helped you find that way. So being a lifeline to new moms without putting extra work on them is something that I found really important as a parent myself.
Excellent tips. Christine, do you have anything to add to those?
Yeah, I think Brydie said it all. But again, the whole food is underrated. It's 100% underrated. As a mom to twins, I thankfully had support set up before they were born so that we would have meals coming. Also, yeah, the just helping people realize that even if they're not struggling during their pregnancy or haven't struggled, I always kind of mention to them, like, if you feel like you want to talk to somebody, like, just get a referral to Women's Health. You don't have to use them all the time. Like, it's not like it's a make or break. Like, you have to go and you have to see somebody. It's just nice to have that support there in place in case.
Support is available.
Mm-hmm.
Mm-hmm. And I think the next part of the question was around supporting someone when they go back to work. Is that right?
That's right. Yes.
Okay. And supporting after when they've experienced postpartum depression, but now their parental leave is over. I wonder, Brydie and Christine, if you have anything to add there.
I would say even if for parents who didn't experience postpartum depression, the return to work is still a challenge. And I did not give women in the workforce before I had children enough credit that sometimes just getting to work, you've already done 2 hours of work in the morning before getting out the door. But I work, actually being a member of the Canadian Armed Forces, I work in a very male dominated environment. And I didn't have the places where I could go and perhaps pump breast milk or go to cry when I was just feeling overwhelmed. So having those employee resource groups or places where they feel comfortable. And so when someone does return to work, having that conversation with them that, yes, these are your professional priorities that we're going to tackle in the first 30 days of you being back, but including in that conversation resources that I know this is a trying time for you, be gentle with yourself, I'm here to support you. Those should be part, if you're an employer or a people leader, those should be part of your conversation. And once again, it shouldn't be the responsibility of the employee. It should be a part of the workplace. And I wish that was a more common practice that we did.
Absolutely. It's so difficult to go back to work for any new mom, for sure. You want to have a soft landing from an understanding employer and a friendly workplace. Christine, did you have anything you wanted to add there about how to support someone coming back to work?
I think that just making sure that you're listening to the person that is going back. There's so much that you have to wrap your head around. You have to find daycare. Most people do anyways, which is basically non-existent, like in terms of finding it. You have to make sure, like Brydie said, you already done 2 hours of work before you came and you're going home to work again. So like just being a listening ear to the people that are going through that, I think is huge. I think that is something that is underrated.
Benicio, I think I saw your hand go up.
Yeah, if I could just add the 50 cent on the support, because this question is so important. Support is actually a risk factor or a resilience factor for perinatal mental health. If you have good supports, you have far less risk of developing postpartum mental health problems. So support is actually huge in our area. And one of the things that really helps people is connecting with other moms. There's several in-person and online peer support groups, and they're incredibly helpful, healing, important. They can help decreasing anxiety, decrease the guilt, normalize the symptoms. They can actually improve a lot of the symptoms that people can feel about, even from depression and anxiety, just by connecting with other moms and understanding that, I'm not alone. There are other loving, caring moms that also have experienced those issues. It normalizes that, gives that sense of hope. Oh, there's somebody that been through it and they came out well on the other side. Like there's so much that can happen on a positive way in peer support groups that I highly encourage. And the other thing is sleep. Support the overnight shift. And this is a shout to the non-birthing parent out there that, if you can help the birthing parent to, divide up the night shift, that can have huge positive, impact on their mental health next day. Because if any of us here don't sleep well one night, we already feel the next day we're not functioning the same way, and we're not, now doing that every night for weeks or sometimes even months, can really take a toll on your mental health and decrease your energy and ability to deal with just normal life stress. So I would say, peer support and the overnight shift support can, really cut down the mental health concerns, sometimes in half right there.
Makes me think that sometimes we know there's some kind of wisdom. We know what we need, and everybody who's had a baby knows I need sleep so badly. And the peer support piece makes me think about when I had my own children. I was in person in an office, and I very luckily had friends. But maybe everybody in the room today can reflect on the way we work today. I know I completely work from home now, and I wonder if there's somebody at work that you may want to be reaching out to, whether it's just sending messages or spending a little bit of extra time at the end of your Zoom call meeting. I think we have time for one more audience question from Hillary.
Great. Thanks, Hannah. So our last question from the audience is around trauma and the way that trauma affects either risk factors for depression, or how it affects the experience of depression in women.
Who would like to tackle this question on trauma and trauma's effects? It has to be someone who's not me. So I'm going to choose Benicio or Melissa.
Yeah, no, I don't mind tackling that. I just want to give everybody an opportunity. So, yeah, huge. So trauma is more and more, you know, understood as, something that can cause lifelong risks. So depending on the severity, depending on the age, actually, that trauma happens, depending on the severity of the trauma, depending on how repeatedly the trauma is, and depending on the person's also resilience to deal with the trauma and support that they may receive or not receive. Some people can be survivors of trauma with minimal, emotional problems, but others can really develop, more severe mental health concerns down the road. We know that even trauma that happens way back when in our childhood can have an impact in our risk for having depression, anxiety, and other concerns as adults. So the perinatal aspect of it, and even the perimenopause, if you will, have both been linked also with greater risk in those people that have experienced significant trauma. The mechanisms are probably multifactorial, part of it can be genetic, part of it can be actually hormonal, but in a different pathway, like the HPA axis, like the stress hormonal pathway that we all have. If we get scared, our stress reaction, helps us, be more attentive and the fight or flight response. But depending on the trauma, that same pathway can become unstable and people can develop more difficulties regulating their emotions, they might be more prone to developing anxiety and depression and irritability and anger down the road. And even the women's health concerns have been associated with more prevalent in those individuals that have had a history of trauma. So yes, it's huge. And I would add to that the help component to it, because trauma therapy is not something very easy and very simple, right? So it's very important people to understand that trauma therapy is slightly different than other, perhaps not so slightly different than other types of therapies. Like it's got to be done in the right setting and with the right approach, being trauma sensitive. Because I've seen people, going out to do, psychotherapy for trauma and came back even more dysregulated than they were when they went to do the trauma therapy. So it's really important to make sure that the person receives trauma therapy at the appropriate setting, with the appropriate professional.
I want to thank the audience for all of your great questions, and I want to wrap up this conversation by just going around and asking everybody what is one change you'd like to see, understanding that there isn't one silver bullet that will solve everything. Risk factors for experiencing mental health issues, it's multifactorial, as Benicio has said a few times. But if there's one thing that you could see today, you'd want this change to happen, I'd love to hear what that thing is from you. We'll start with Melissa.
Oh, that's easy. For me, it would be no more stigma. And I think we're going to get there with the next up and coming generations. So I'm very optimistic.
Thank you. Brydie.
I guess mine would be to stop making women's health problems only women's problems, to have other people involved in process. And that includes things like funding and helping those who are affected by it. So to stop making that burden be solely on women who are already traumatized with what they're dealing with.
Thank you so much. Christine.
Yeah, I think just the access of care. There's long wait lists for any care, especially for postpartum. I'm assuming for perimenopause and menopause as well. So just figuring that out, like it shouldn't be so hard to access the care.
Excellent point. And to Benicio, what's one change you would like to see today?
More education, not just public education, but educating the next generation of professionals. I don't think the women's health issues are highlighted enough at the core of the, institutions that are related to any profession, psychiatry, medicine, psychology, social work, nursing, doesn't matter. Women's health should be one of the core, domains that people are trained on, so we can have more help out there for people that need the help.
Absolutely. And I can't think of a more important topic really than the one that we've discussed tonight when it comes to women's mental health and the untold stories, which was the title of tonight's talk. I want to thank all of you so much for bringing those stories to the fore. I want to thank Dr. Melissa Perreault, Brydie Huffman, Christine Vanderveen, and Dr. Benicio Frey. Thank you so much for your time and for your wisdom and your energy tonight. I also want to thank the HRI staff for their work behind the scenes to deliver this talk, and I'd like to thank the audience for joining us and for your interest in this topic. Thank you so much, and I'll hand it back to Hillary.
Thank you so much, Hannah, for moderating this evening's talk. If we didn't get to your question this evening, you can reach out to us at hriresearch.com. And if you haven't already done so, while you're on our website, you can subscribe to our HRI Talks mailing list and our quarterly newsletter, and follow us on social media to learn more about our next HRI Talk, which will be happening in the fall. So once again, I'd like to thank our corporate sponsor, CIBC, and our supporting sponsors, KPMG and the Otsuka Lundbeck Alliance. We're so grateful to our sponsors and to all our supporters across Canada and across the world. Thank you, everyone, for calling in tonight and being a part of the event. We'll see you next time. Good night.